Good morning. This is an introduction to orthodontic care from the Darby chapter. Um, as far as orthodontics, we will see orthodontic patients in our practice on a regular basis. As you start practicing, you learn a little bit more, and there is overlap in our courses on oral hygiene and focus on orthodontics as well. But today we're going to discuss a little bit about oral hygiene, and we'll also discuss some of the skeletal discrepancies that may occur. Malocclusion can cause a lot of different issues. We're going to kind of why we're assessing this as a dental hygienist in our referrals, and with us as a hygienist, the education for the patient as well is extremely important, and a lot of different considerations that we must take a look at and take into consideration for the individual patient. And we'll also discuss a little bit about the biomechanics of the tooth movement, kind of discuss some of the different types of orthodontic treatment that may occur. And also in class this morning, there were several people that has had orthodontic treatment and different types of intervention that we discussed as well, and some of the different appliances that are used that you may come across. Orthodontics is a dental specialty that deals with basically the recognition and the prevention of treatments with irregularities or the malocclusion of the teeth, the jaws, the face, and how this plays a role in the physical and also the mental health or psychological health of the patient. We really have to, some of the things that we think about when we look at orthodontics and our goals that we want to achieve. We really want to establish a long-lasting, normal functioning occlusion. Also improving the facial aesthetics. We can get with a class 3 or a class 2 or a lip protrusion, it can really cause some deviations in how the facial aesthetics look. And then also we're looking at the long-term stability for our orthodontics. And as I mentioned earlier, the psychologic position, the physiologic position of the condyle, and also the psychologic aspects for the patient. And if we have a lot of crowding and tooth movement, we can also see a patient that's more prone to periodontal issues as well. So we can see that there are problems with the malocclusion. We can see a genetic discrepancy, and then also we can see different discrepancies due to trauma or maybe some parafunctional habits that maybe the patient has had. For instance, a patient that may have a tongue thrust, or a child that has sucked on a pacifier too long or sucked their thumb. Effects that can be seen with malocclusion, again, as I mentioned earlier, the psychosocial problems. People, if you notice, that have a open bite or discrepancies on their severe malocclusion, they don't really smile a lot, or they'll put their hand over their mouth. We look at some of the oral function problems. They may not be able to have proper mastication or some TMJ. When they have crowding and overlapping, they can have a lot more biofilm, a lot more stain, much more difficulty in regular oral hygiene, and again, may have a tendency towards periodontal disease issues, especially if there's teeth that are missing or that have really drifted forward due to another missing teeth. And then again, if there's been some trauma or breakage of the protruding teeth, or there had been an accident due to the teeth. And then also we'll see problems with TMJ issues as well. In this image, you can kind of see where this patient has what they call lip incompetence, and it really causes some protrusion due to that dentition. We see some lower anterior crowding with this patient, and then we also have some issues with some biofilm right in here. You can see some of the redness. We can see all of this mandibular crowding. We can see how this tooth is at an end-to-end bite as well. We have definitely some dysfunction in some of this area. We got this tooth right over here with this canine in this lateral and a little bit of a cross bite as well. This is another image of lip protrusion or lip incompetence. You can see in here where the teeth have a very severe overjet on them, and that again, that could be to either a tongue thrust that the patient might have. That's another parafunctional habit that a patient has. There could have been trauma to these teeth, but again, you can see that lip incompetence causes that protrusion there. They may have, again, with the tongue thrust, or they may be a mouth breather or have some other issues as well. Doing your examination and assessment for the evaluation on a referral, several factors that we must consider for this patient. You want to look at their medical history. Are there any medications that might cause some gingival hyperplasia? And some of those can be like a hypertension medication. There are some organ transplant medications that can cause some gingival hyperplasia. And also some epileptic seizure medication can also cause some gingival hyperplasia as well. So that's one reason we always like you to look up your medications, or even when you're in practice. If you're not familiar with one, look it up. We're always going to do our intra-extraoral assessment. Again, we want to look at that skeletal formation. We're looking at how the patient swallows, looking at the, do they have a sleep apnea issue that may be causing some of their tongue thrust. We'll take pre-assessment photographs, radiographs. There's several different types of radiographs that may be exposed. We'll a lot of times take a panoramic x-ray. A cephalometric x-ray takes a lateral view that can look at some of the skeletal growth. And then we'll also have impressions taken, or digital scans as well, throughout the time that the patient is in their orthodontics. They may take a beginning, may take some in the middle, they may take some at the end as well. Other aspects we're looking at, not only do we look at like our angles classification, we're going to look at the transverse plane that goes across like this. We're also going to look at the sagittal plane, that antero-posterior, and as well as the occlusion or the occlusal plane with that. So that is something usually a class 2 or a class 3 is in that transverse type of plane. So quite a bit of aspects that we have to look for. We look at the eruption pattern, we look at the medications. Do they have some congenitally missing or impacted teeth? What is our natural occlusion? They may take a CBCT that, if there are impacted teeth, can show exactly which way that impaction is laying, whether it's a wisdom tooth or an impacted canine or a premolar. This image we have, if you look right here and you look right here, we've got posterior crossbite on the right and left. We have a bilateral crossbite on both sides. This could be, you can see some of the arch a little bit narrow here, so that may have been some type of skeletal deviation that the maybe a palatal expander when that patient was younger, that could have helped correct that. We look at the age of the patient. We kind of look at the skeletal age, chronological age, and their dental age. And that is something they look at for orthodontic treatment as well with the orthodontist. There's several factors that we look at with occlusion, and we're not only looking at the eruption and the position of the teeth, but we also look at the skeletal growth of both the maxilla and the mandible. In the adolescent, there's a lot of growth. So that is something that when the orthodontist is timing some of this treatment, they really have to be careful to take advantage of some of the different growth spurts for the children. We look at the skeletal age of the patient. They look at the chronological age in years and months. And then they also are looking at the dental age. And that's what we're looking at, how the teeth are eruption. We're looking not only because in our dental age, a lot of times we're going to have the eruption pattern may be 6-7 months earlier, or 7 months later, or even a year later on some children. I had told about my grandson this morning. He was very delayed on any of his teeth erupting. He was almost, a year and a half before he really started getting anything more than the 2 mandibular incisors. But sometimes there may be a child on an average, like our first molars, we call them their 6-year molars. But some children get them earlier. Some children get them at 6 or 7, that latter part almost 8. So that is more, we look at that eruption pattern. Are those 6-year molars coming through when they're supposed to? Or did they lose teeth too soon and the permanent teeth are starting to erupt? So we really, that chronological age, we isn't quite as important as that eruption pattern. And it's really important. I know we look at those eruption patterns and ages, and we want you to know those. So that's the important thing to know. Those have that knowledge of the eruption patterns is to really recognize any abnormalities that you might be seeing as the child grows. Some of the things we look at are over-retained primary teeth, that maybe the permanent tooth's erupting sooner than it should, and the primary tooth is not lost. Do we have congenitally missing teeth? A lot of times we're going to look at second premolars or those lateral incisors. Those a lot of times are congenitally missing. And our panoramic x-ray, when we take one of those, that really helps us target and look at some of those missing teeth. And the dentist can refer to the orthodontic as we're getting closer to that age to kind of address those. Do we lose the primary tooth too soon and the permanent tooth wants to erupt too soon? Or will it cause shifting of the permanent tooth behind it? Do we need a space maintainer? How crowded are those mandibular incisors? Again, those mandibular permanent teeth are much larger than the primary teeth. Did the child, as a young child, have the proper primate spacing between the teeth? So a lot of parents have concerns when they see that primate spacing, and I think my child has the spacing between their teeth, which we really want to see that. We don't want to see perfect alignment of that primary dentition without any primate spacing. If we see no primate spacing and some crowding on a primary dentition, then that's usually cause for concern, and we really watch that young child as their teeth, especially as their permanent teeth, should be erupting. Midline diastemas, most children are going to have a midline diastema when that 8 and 9 comes in, and kind of as the other teeth erupt, that closes. But then, as they get older, we kind of look at that, and does it close or does it not close? Then we look at the shifting. Would we have a midline deviation? What about lingual eruption of permanent anterior teeth? And then we look again, probably the most common teeth that we see impacted are the canines. And again, are those impacted? Are they going to have to be moved down, or will spaces close too soon? So the orthodontist can really make some intervention in that area. And again, lack of space for our premolars. The premolars are a little bit larger than our mandibular molars, and if there's some shifting or the tooth has been lost too soon, we won't have a proper spacing for those teeth to erupt as well. So all of those come into play. You need to be very considerate of what our eruption patterns are for a child. These are just some of the different radiographs that may be taken before a orthodontic intervention. Again, most of us in practice are going to be taking panoramic x-rays. We always take one here at the school. In this one, we can kind of see there's the third molars. We know the second molars. We know all the premolars are there. We can really see, okay, this child has all of their teeth, and they look pretty well on target. We've got, when they get a little bit older, they have some third molars. This right here is a CBCT image right here. If there are impacted teeth on the CBCT, they can actually see how, say, if there's an impacted canine, how that is located within the bone, and how the oral surgeon might have to do the extraction. Look at the biomechanics of tooth movement. The tooth is going to be moved just because there's that light pressure on it, and it's going to be consistent on there. It has to be at least 6 hours. So that's sometimes why retainers or Invisalign really have to keep that, or keep that pressure on it. Or when someone's wearing a rubber band, they'll say, wear that rubber band to attach this every night while you're sleeping, or at least 8 hours a day or 6 hours. A lot of times they'll make those guidelines. So it's like how long the force is on there, then it's the length of the time that the force is on there versus the strength of the force. So then our osteoclastic and our osteoblastic activity, that's going on within that periodontal ligament, and just kind of changing and shifting as the tooth is moving. And then also that's why we see these orthodontic appointments are usually not more than 4 weeks, but usually every 4 to 6 weeks. Usually within 10 days is when we start to see the tooth movement. Then it takes about 10 to 14 days to kind of stabilize that. So that's usually why every 4 to 6 weeks that appointment is made for orthodontics, and they change the wire and restart that movement all over again. This is just kind of an image. It shows, here we go, we have the periodontal ligament. We have force placed on the tooth to movement. To make that movement occur, there's the tension, because it's pushing, we've got it. And then here's the compression. So here's our new bone here, and then here's our bone resorption. And then as it kind of moves, we got the new bone, the tooth is shifting a little bit. Then we change that wire, and it starts every several different types of orthodontic interventions. There's 3. So what we're looking at is phase 1, phase 2, and the retentive phase. Phase 1, that's going to be usually an early intervention. That's when we're looking at children, the smaller child, the younger child, what our eruption pattern is. This is where we might use some type of, they have a tongue thrust or they're thumb sucking. We might use an appliance, or they might use some type of palatal expander to make that maxillary arch open more naturally if they see a really narrow arch on the patient. So that may be some type of retainer or some type of space maintainer that's moved. Usually these early phase interventions don't last quite as long. And then you move to the phase 2 when the patient is becoming an adolescent, 12, 13, 14, 15 years old. And again, that's where those interventions where we're usually doing that active treatment in the full braces for the patient. And then we're looking at the final phase that we're looking at more our retentive phase. And that's where we're maintaining it. We're making sure all the movement has been done, and the patient is also going to be wearing their retainers or the appliances that they wear either for 6 months or a year, or sometimes there even has to be a bonded retainer on some of the maxillary or mandibular anterior teeth. I have this image down here to the lower right. Here you can see where this patient has their permanent anterior mandibular incisors. Then we're looking, the 2 laterals have not erupted, and here they're erupting right behind it. A lot of parents will ask you, do these teeth need to be removed? Sometimes you'll see them come right behind these 2. Sometimes you'll see them right behind these. What I usually tell parents, and most of the dentists I work for, we watch this. Do these teeth have some movement? Do they have some mobility? Most of the time, if they have some mobility and the child can move them, then they can wiggle them out of there. If we take an x-ray and we don't see any resorption of this root, or say for instance this root here, then those teeth may have to be removed. But again, if we have a radiograph taken and we see resorption of that root and the child can really cause that tooth to wiggle and move, then you may just let them wiggle it out of there rather than try to help it out of there. Here's some of our different orthodontic appliances. This one is what was our Invisalign up here on the upper right. And then also this called aligners. They are worn for quite a while today, during the day. Again, we had a lot of questions on this morning about the aligners, and it's a difference in the patient's case. These aren't used for very severe cases of ortho. They're mainly used for something that's going to be some more simple tooth movement. And sometimes it might be that they come in every week, they might come in every 2 weeks, and sometimes depending on the movement, they may make a new aligner every month for this patient. They take scans, they make new trays, and they have the little buttons on the teeth that apply pressure and help with that tooth movement. And then right here we have down here where they have an arch wire, and here's one actually has a arch wire embedded into the, a tab embedded into the bone, and the rubber band can actually attach here, and it's probably attached to a canine anteriorly to help move these teeth. And this is just traditional brackets with retainers on them. And those usually, on average, take about 2 years. Sometimes we may see them worn a little bit longer. And again, that depends on the patient. Their compliance, a lot depends on that. A lot depends on the severity of the case as well. So there might be brackets, there might be tubes, there may be palatal appliances, and then again, some of these, like these anchoring devices that are located in the gingiva or in the tissue. Shows a few of the different devices that may be used. Here is a tongue guard appliance. You can see right up here on the palate. This may be used for a patient that has a tongue thrust or a thumb sucking habit that will prevent them from doing that. That's another parafunctional habit. Here is a palatal expander if the patient has a really narrow maxillary arch and they want to expand that and really round that into a normal arch. This is a Herbst appliance. It is actually trying to help. It's retained onto the maxillary and helping to maintain this mandibular arch and help with that occlusion to become more natural. It actually pulls that mandibular arch forward to help become more, if it's in a class 3, to help be more alignment with the maxillary arch. This is a holding appliance. They may wear that temporarily in between orthodontics, especially if there's been some palatal expansion for some time. And then here is headgear, and that just depends. That can be on a class 2 or a class 3 patient and how they're going to be shifting that arch. Again, these are for much more severe type, the class 2, class 3 type of malocclusion. Talking a little bit about the orthodontic forces on the maxilla, so that's the maxillary growth right at that maxillary suture. That's in the mid-palatine suture area. So that's where that growth modification with those palatal expanders really do help to kind of open that, or if they have too much growth, they can maintain it and stop it. So if there's too much growth, there's a deficit growth on that. Sometimes, depending on the class 2 type, they may wear the headgear that are appliances, and that can either restrain some of the maxillary growth, or they can also be applied for the class 3 malocclusion as well. A lot of they really try having the headwear mainly worn at night because that's where you see more of the growth hormone in children, is what the speculation is on that, is during the nighttime. Orthodontic therapy, there's that constant resorption of the bone, and it also is the dentin and the cementum are in there with the associated with the orthodontic movement as well. There's the cementum and the dentin. They're kind of have the force as well, and then it helps replace that cementum during the rest period after the tooth movement has been accomplished. It's really not, and no orthodontics has really been associated with an increase in the loss of alveolar bone, but they do have to be careful, and there's some thought that it can cause some resorption of the roots in some teeth if the orthodontics has been moved too quickly. It may be something genetic as well. They're not 100% sure when that root resorption occurs, but that thought process is maybe the teeth have been moved too quickly. A lot of times with tooth movement for the first 2 to 4 days, patients do have some tenderness or some mild pulpitis. It makes it hard for them to chew, hard for them to eat, and a lot of times recommending a softer food for a few days is very beneficial. Some patients will, with the orthodontic brackets that you see, those of you who've worn ortho, you know that it can rub some of that mucosa, and so you recommend wax for your patient on that. For those of you who have not worn it, definitely can cause some ulcers to occur and become very tender. And then some of the periodontal inflammation that can occur as well. Some of the other concerns that we see is white spot lesions. We look for decalcified enamel. Is the patient keeping their teeth clean? Is some of this decalcification due to the dental cement? We look at their oral hygiene very, they have to be very scrupulous with that oral hygiene. So we have a little bit of that pulpitis. We look at some of the issues with some of the keratinized tissue. We may see some mucogingival defects in some of the gingival recession and around the non-keratinized tissue as well. Final phase of orthodontics, we have our retention, hopefully no relapse, but it does occur. We have to have sufficient time for the gingival and the periodontal tissues because we've had that to form because of that widening of the PDL, and those supporting collagen fibers have been disrupted. Sometimes the orthodontic relapse occurs because of the skeletal growth of a patient as well that occurs. And that's why a lot of times wearing that retainer, patients are told to wear their retainer for some time. In this image down here, you can see where there's been a first molar missing and the tooth has really drifted forward. And orthodontics can actually, that's a third molar, that's a second molar, first molar's missing. Orthodontics can pull that up, shift all these teeth forward, can take where this tooth is missing, can pull this molar up and then shift all these teeth forward. But then they would really need to be wearing their retainer and be watching very closely with the orthodontics that they don't have any relapse in their case later. Orthodontists also work quite closely sometimes with a periodontist. We have to look at some of the, like in this area where we have this tooth has been shifted forward, that really loses that bone in there, and then also very thin cortical plate right there with that bone. So a lot of times it will have a mucogingival defect that occurs. So a lot of times you have to have the patient referred to the periodontist, and they'll do some type of gingival graft there. That occurs in orthodontics is the implant site development. So a lot of times if they're going to place an implant, they want to have a good quality of bone in that area for the implant, that they don't have to do a lot of bone grafting, especially for a long-term good prognosis for it. So sometimes if the tooth has been extracted and it already has extruded all the way through before it's extracted, then it's going to have a lot better bone level for that implant placement later on. Of other specialists that might become involved in an orthodontic case, we have orofacial myology, and then we also may have a speech therapist. An orofacial myologist can actually do therapy with tongue rest, corrective swallowing, the way the breathing occurs, and helps make modifications in that. And there are certifications in some states that there are hygienists that get a certification in orofacial myology and work with orthodontists and speech therapists. Sometimes also a speech therapist may have to help, say, someone if they have a lisp or some type of tongue issue. If they had to have a frenum, they were, for instance, the tongue-tied type of thing, where they had a lisp and couldn't speak properly. The speech therapist, after that surgery has been done, can help the child learn to speak properly. These are just some other bonded retainers I wanted you to take a look at that you may see in practice. I think this is just a bonded retainer. Sometimes you'll see it bonded tooth by tooth by tooth by tooth by tooth, like this one is from canine to canine. Other times you'll see it just bonded on the canine to the other canine, and then it makes it much easier for the floss threader to enable it to clean back there much better. Here is a fixed retainer, similar to the Invisalign that some people will wear those, and they wear that on a regular basis for their retainer. This just kind of, this lower right area gives an image of, say, an Invisalign with the different retainers that have been, here's one where you can see this alignment here to the left. Then a couple of weeks later, there's a little bit of change. And then right here, it's into place where they would like it. And then they'll just wear the fixed retainer, the clear type retainer, for a length of time. Here is just a traditional retainer that a lot of patients will wear at night for retention over a fixed period of time. And it may be anywhere from 6 months to 2 or 3 years, or a lifetime, or if they start to see some shifting, they'll wear their retainer. I want to discuss the role of the hygienist in orthodontics and the long-term effects with this. We always have to look if there's some periodontal issues or if there is any decay. That kind of falls under that Hippocratic oath and non-maleficence, that we can do no harm to the patient. We have to do restorative treatments and periodontal issues. That's a priority even before correcting the malocclusion. If a patient is not going to take care of the periodontal issues nor the decay, then we cannot ethically put orthodontics on knowing that there's active decay or periodontal issues. After their initial referral and their treatment's completed, then they will have comprehensive oral exams on a regular basis. They have to keep that up as well. They can't just get their restorations done, get their orthodontics on, and then not come see their dentist or dental hygienist for 2 years. We're always going to do assessments. We're always going to look at dietary interventions, especially if we take radiographs and we see some active decay, if we see some poor oral hygiene, if we start to see some white spot lesions, or if we have to, highly recommended is an oral irrigator. This aspect right here, they're talking about oral irrigation for 6 to 8 weeks on fixation. And that's if someone has had a surgery that they had to have a mandibular type of surgery and their maxillary and mandibular were wired together due to that surgery, and they might have to use a very soft toothbrush, some swabs, and an oral irrigation with chlorhexidine till it heals up. We had a lot of questions about these white spots this morning and how we address those, or do they go away on patients? Sometimes this remineralized, remember remineralized enamel is going to be very strong. However, the discoloration, sometimes we can use what's called an MI paste. That really does help to remineralize this and make it, it's made with milk caseins, and it really does help camouflage this. It does not look so bright to the patient. Usually if they're going to have restorations, they usually like to wait for at least 6 to 8 weeks, and they'll also have them discontinue use of their fluoride for a little while to see how everything's remineralized. If this still has this severe of discoloration, a patient has maybe whitened, it might even out these tones. The MI paste may even out these tones. If it keeps like this, then a lot of times it's more of a cosmetic intervention. But a lot of times patients can do the whitening and really make it much less obvious for the patient. So, and again, that's case by case. We don't always know how that's going to work out. And a lot of times we just hope for the best results with that. And the patient is satisfied. Considerations, we're going to look at Charter's method, we're going to look at the Stillman's method. We're always going to be getting up along that gingival line. We'll look for any clefting. You can see in the upper image how we really have to adapt below that margin. We also want to get above that margin both ways. So that's where the power toothbrush is recommending a power toothbrush for a patient, using a Proxa brush, using an oral irrigator. So we really want to look, and we can even use chlorhexidine for a patient if they have some gingival irritation. A lot of this, and that's why we really look with the adolescent population, they are sometimes notorious for not keeping their teeth as clean as they should, and we really encourage parents to follow up with them as well. We might even send home a disclosing agent with them. So oral hygiene is something that we're always going to look at and also document about that patient and how their oral hygiene is doing and what kind of recommendations we've made for them. Look at some of the mechanical techniques for oral hygiene. Of course, here's our power toothbrush. There are specialized toothbrush heads just made for orthodontics that actually has a little depression in here with shorter bristles in the middle that fits over the bracket, and then it has regular bristles on the outside. Those are great. You can find those online, or some places will carry those. If there's some proxy brushes that you might need to get in some specific areas, these can also be dipped in chlorhexidine if there's an irritant somewhere. Using our floss threaders, as you see down here, really makes a difference on a daily basis. But that's kind of hard to do for a lot of patients and flossing on a regular basis. So using a water flosser, power toothbrush and water flosser are ideal for using for your orthodontic patients and getting their oral hygiene. Ideally, when they come to see you, this little arch wire right in here, there's a clear type of brackets, and here's the regular traditional, but this arch wire, some patients will have this removed. Makes it so much easier to clean when they come in to see you. Sometimes our patients, because we have ortho right downstairs, they may come in and see you in the morning and get these arch wires taken out. And then when you're done cleaning the patient, they'll go back down to ortho and get those arch wires. Or I would have patients, we had an orthodontist right down about 2-3 doors from our office, and they would coordinate appointments with us as well. If it was one of our patients, they would take the arch wire off, recut it, come down, they would have their teeth cleaned by one of our hygienists, and then they'd go back down to their orthodontist and get the arch wire placed back on. That's ideal if you can do it. Next, some of the different antimicrobial agents. Of course, we're going to use a fluoride toothpaste. Most often it's recommended, and a lot of orthodontists will give the prescription for some type of fluoride gel. They are a great antimicrobial. This PerioMed works great. It's a stainless fluoride that works great for perio issues, and it doesn't stain. Some people it does, some people it doesn't, but it doesn't stain like the chlorhexidine. But the PerioMed can be made into a rinse that some people will use. It's prescription strength, but really using this in conjunction with mechanical methods is very effective. Again, we can use chlorhexidine, sometimes the essential oils like with Listerine or the CPC. All of those are good antimicrobials, especially if we're starting to see some inflammation, and the patient can use that twice a day. Another fluoride, Prevident 5000. This one is called Ortho Defense. They have one for dry mouth. They have one just for caries. We don't really use the APF. Again, this one's more of a sodium fluoride, but we can get that in our clinic. We just discuss it with the patient, and if they would like it, we can get that filled right then. Not always in ortho downstairs on the 3rd floor do they prescribe this Prevident 5000. So if we do see some poor oral hygiene or some white spot lesions, let's really address this with the patient and talk to Dr. Reisner about a prescription for this for our patient, or with your instructor as well. The Prevident 5000, they would use that at least daily. Usually we'll use that at night. In our offices, we're usually going to do a fluoride varnish because usually an orthodontic patient is at a higher caries risk. We don't really use our APF gels very often, but you might be in an office that does. Those are usually not used if there's any, it's an acidulated phosphate. We don't usually use that with cosmetics. And then again, our home fluoride gel that might be used either with a brush on, or sometimes some patients will use a tray. Important aspect of orthodontics. We look at our dietary counseling, looking at that patient. Do they eat a lot of sticky foods? Sometimes some people will eat a little bit softer carbohydrate foods. Maybe if they can eat their sweets with their meals instead of snacking on like sticky gummy bears or Jolly Ranchers or things like that. But we really want to look. We have to always look. Do we have any dental caries? What's our white spot lesions? Again, and if that food debris is caught in there, we want to give our patients maybe a little proxy brush that's a pocket size, that they can use at school, that they can kind of go look in the mirror and clean in between the teeth if they don't have an opportunity to brush their teeth. So we really want to look at all of those aspects and even encourage our patient to rinse even during the day to keep that food from impacting and causing caries around their brackets and braces. You, as the hygienist, you are the motivational communicator. Use those open-ended questions, asking them, what can I do to help you with this? Is there something, do you mind if I show you this? Ask the patients how do you think you're doing? How is your brushing doing? How often are you brushing, morning and evening? So asking them those open-ended questions. And some offices actually kind of will even develop a script about it. And sometimes beginning clinicians kind of like that because they really know what to target with the patient. This is like an upside down. If you notice anything with this, somehow or another, this image is upside down. Anyhow, then We're always going to look at that oral hygiene, their overall health, updating their medical history, and then again, what kind of care we provided at each visit. What kind of recommendations did we prescribe fluoride for them? Do they need to use a proxy brush, chlorhexidine? Did we show them Listerine with fluoride to use and rinse with twice a day? Anything that you feel is going to be beneficial with that patient. This just shows a little scoring. We have excellent. This is good. You can write that that's good. And this was actually, I think this one is in your textbook, but I've actually seen this posted in some orthodontist offices as well for patients to look at. So you can actually show these to patients. How are they doing? Are you average? If you see some redness or some gums or some swollen areas, if they have bleeding when they're brushing, if the gums are really swollen like this. So this is a good visual for patients to have, not only us as clinicians, but for the patients as well. Here in this image, this just looks great. I know you guys have been taking photos for case studies. These are some ideal photos of a post-ortho case. We have the facial. We have our side views that we're back here at these first molars. Look at that arch. Look at both of these arches. This has just been an ideal case, and that is something that most patients want to have happen after they've spent their 2 years in their braces. So if you have any questions about this, most of this is in the textbook as well. I tried to align with some of the information that your text has. It may so you can kind of get this introduction to orthodontics. So this is the last little questions. I just had to show my little grandchildren at Easter. There's their little Easter veggie tray that they had to have that day. So we had fun making that. A fun time at our Easter egg hunt. So anyhow, I will get this posted today, and there will be a quiz over this information next week.